Our first speaker today is Martin Watts. Martin is a student at UAMS and UALR, or
just UAMS.
Both okay, UAMS. He is doing a doctorate in neuroscience. Is that right?
Mm-hmm.
And he's also a medical student. He has been doing research in neuroscience on pain and is here to talk to us today about what he's been doing.
All right, thank you. Volume okay? All right, well, thank you all for coming and for bearing with me while I talk through this cold. So what I would like to do today is kind of a pre-defense warm-up, I guess. But I know this looks like a lot of word salad, but hopefully by the end it'll make some sense to you. And if we don't get through all the research stuff, that's okay. Feel free to interrupt me if you have any questions, because the first part is the most important stuff. Okay. So my research was focused primarily on pain. If we all experience pain, and so when I use the word, you all know what I'm talking about. But if you had asked me to define it before spending some time in the lab, that would have been a difficult thing for me to do. It's a subjective thing that sometimes it's hard to put a definition to, but luckily we have an International Association for the Study of Pain who has taken the time to give us a nice definition that's pretty universally accepted, although it's somewhat incomplete. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. An important thing to note about this is it's an experience. It's subjective. And we have difficult time measuring pain. When you go to the doctor, about the best they can do is say, you know, on a scale of 1 to 10, 10 being the worst pain you've ever felt, what is your pain? And that's really not very helpful. But it's the best that we have. Now in science, in the lab, and sometimes in medicine, when people talk about pain, what they actually mean is nociception. So this is the activation of neurons, or pain fibers, that transmit pain signals. Now nociception can occur without you experiencing, as happens if you take morphine. Or you can actually have pain in the absence of nociception. And we'll talk a little bit about that. And importantly, pain is the most common reason that people seek medical care. As such, physicians kind of view pain as the bane of human experience, which isn't quite a fair way to look at it, because pain is adaptive. It's what tells us something is wrong. There's some kind of damage either occurring or may occur. And so there are actually kids who are born with a congenital insensitivity to pain, also known as congenital analgesia. And oftentimes these kids don't live very long. They self-mutilate. And you see a similar thing with diabetic neuropathy. Somebody will get a sore on their foot, they don't realize it, it gets infected, and then it gets amputated. So what we really need to focus on in medicine is pathologic pain. Pain that's not helpful. It's not adaptive. And we call this hypersensitivity. This is an increased sensitivity to painful stimuli. It encompasses two phenomena: allodynia, which is pain in response to a normally non-painful stimulus. This happens with patients who have, say, trigeminal neuralgia, and just the wind blowing hurts. Or if you have a sunburn, the sheets can become very painful. Hyperalgesia is an enhanced response to normally painful stimulus. So something that normally hurts now hurts more. And we have a little schematic over here on your right that kind of to illustrate what we're talking about. The dotted line represents the pain threshold under normal circumstances. And in the case of inflammation or some sort of pathology, that threshold will decrease, and this would be allodynia. Anything to the right of the threshold, so suprathreshold pain, becomes more painful. That's hyperalgesia, and everything in blue represents hypersensitivity. My work focused on visceral pain. So normally when we talk about pain, we think about burning your hand, hitting your hand with a hammer. Visceral pain is pain of the internal organs. And the reason that we bring it up is, one, it's probably the most common type of pain that people experience. And two, it's different. It's often more difficult to treat as well. And so how is it different? Well, it's not elicited from all organs. For instance, I can't make you hurt by poking your liver. It doesn't necessarily correlate with injury. You can use local anesthesia to do surgery on somebody's colon, because cutting the colon doesn't hurt. And obviously that is a significant injury, whereas a small amount of gas can be unbearable. It's diffuse, it's poorly localized, so when you're having abdominal pain, you can't point to it. If you hit your hand with a hammer, you can say, my hand hurts here. But with abdominal pain, you just say, it kind of hurts here, there. It's often referred. So the best example of this is a heart attack. You may have some chest pain, but you oftentimes will hurt in your arm, your shoulder, your neck instead. And this happens because the nerves that innervate, say the heart, synapse in the spinal cord at the same place that the nerves that innervate the skin do. It's often associated with autonomic reflexes, so again, if you hit your hand with a hammer, you're probably not going to throw up. But if you have a heart attack, you might. And it's transmitted to the brain through different tracts in the spinal cord. So let's talk a little bit about some mechanisms and anatomy. On the left, we have the way that, say, touch sensation is transmitted to the brain. These neurons live in the dorsal root ganglia. It's a ball of cells outside of the spinal cord. And they have axons that go into the periphery, so the skin, and then they send an axon to the spinal cord. In the case of touch, those axons go up to the brainstem on the same side as the stimulus, synapse on a new neuron. That one sends an axon that crosses over to the other side to the thalamus, which is a part of the brain that serves kind of as a relay between the cortex and the lower brain structures and spinal cord. Pain is different. First of all, pain receptors synapse in the spinal cord. Instead of going up to the brainstem first, they synapse on the same side, and this is called the spinothalamic tract, which you have to like neuroanatomists who do spinal cord work, because they name things in an intelligent way based on where they are and what they do, unlike the brain people who name things based on what they look like the amygdala. So they synapse in the spinal cord, and that sends an axon that crosses over at about the same level, usually a little bit higher, and that goes up to the thalamus, so the spinothalamic tract. Visceral pain is strange because it's kind of a combination of the two. So the axons synapse in the spinal cord at the same place, but then it travels up with the neurons from touch in the dorsal column. And so then those will synapse in the brainstem, And that neuron here will send an axon up to the thalamus. So it's called the postsynaptic dorsal column. One more little anatomic factoid that's important is the types of fibers that transmit sensation. So touch is transmitted through what are called A beta fibers. These are large and myelinated. Myelin is the insulator for neurons, and they transmit signals very quickly. And then there are two other types, A delta, which are small neurons, small fibers that have insulation, and C fibers, which are small fibers that do not. And so A delta fibers transmit signals a little bit slower than A beta. And so again, if you hit your hand, that first sensation that makes you jerk back is transmitted through A delta fibers. And then a few short seconds later, you'll have kind of a new achy pain. And those are transmitted by the slow C fibers, which innervate the viscera predominantly. So again, my work was on not only visceral pain, but visceral hypersensitivity. So this is an enhanced perception of visceral pain. It's pain that is more severe than it should be. It can be caused by a number of mechanisms. Peripheral sensitization, which is sensitization of the, those dorsal root ganglion neurons that we talked about, the pain fibers. Central sensitization, which means that neurons in the spinal cord, thalamus, or cortex are more likely to respond to painful stimuli. Psychological factors, depression is associated with an increased sensitivity to pain. Or descending modulation, and this is your endogenous opioid pathway. So if it's reduced, as happens with rebound pain following opioid administration, you can have hypersensitivity. So again, peripheral sensitization is enhanced sensitivity of these primary afferents. An afferent is just a fiber that goes to the brain. Efferent means from the brain. And one thing that can cause it is inflammation. Inflammatory mediators or molecules involved in inflammation can have a direct action on the neurons, which is very fast. There can also be slower, longer lasting changes through protein modification. In this case, the addition of a phosphate group to the protein. You can have changes in gene expression, so increased or decreased amounts of protein. And you can have activation of silent nociceptors, which is a really cool phenomenon. In the dorsal root ganglia, there are actually neurons sitting there doing nothing. And after there has been prolonged inflammation, all of a sudden they become active and you have increased input to the brain. So we studied inflammatory bowel disease. So we talked about visceral pain, visceral hypersensitivity in the context of inflammation. And so there are a few diseases where this occurs. Pancreatitis is one, and of course inflammatory bowel disease. If you're writing a grant, you want people to know why it matters. So it's prevalent, it's a problem. At least 1 million people have it. And if you want politicians to care, you need to tell them how much it costs. And it costs at least $2 billion annually. And these are conservative estimates. Of course, it's characterized by a chronic inflammation of the bowel. And it's associated with hypersensitivity or increased pain. It hurts. The treatment stinks. We can give immune modulators to kind of decrease the pathology, but they're not very effective. You have refractory disease, and people have pain even when they're in remission. Medications that we have to treat pain, say ibuprofen, you can't really use because it causes, it can cause damage to the bowel on its own. Opioids can make symptoms worse. For one, they can cause rebound pain that's worse than the pain was to start with. They can also directly sensitize the pain in the colon through some interesting mechanisms, but it basically kind of has the opposite effect of what it should. So there are two main types. There are actually several, but the two predominant forms of inflammatory bowel disease are Crohn's and ulcerative colitis. And we studied predominantly Crohn's disease because our rat model most closely mimics it. It's associated with diarrhea, skipping lesions. This means that you'll have areas of the colon that are inflamed with areas that are not, of normal tissue in between. Transmural inflammation means that the entire bowel wall is inflamed, and so you can have fistula. You can get holes in the colon, and this is a serious problem. Granuloma formation, that's basically a fibrotic ball of macrophages, the Pac-Man of the immune system. And visceral hypersensitivity. So we use a rat model of inflammatory bowel disease. Excuse me. I know we're all from different backgrounds, and some of you may be opposed to animal research in general, and those of you who are not may be a little squeamish about using rats in pain research, and honestly I am too. So we take great care to be as humane as possible. And they're sedated during all procedures. And you can do that because the way that we measure pain in these animals is it's a reflex that goes to the brainstem and not the cortex. And under anesthesia, the first thing to go to sleep is the things at the top. So how do we induce inflammatory bowel disease in a rat? Well, we inject a hapten into the colon. A hapten is a molecule, you're probably familiar with poison ivy. And the way that it causes inflammation is when it binds to protein, say albumin or something, it becomes antigenic and can induce a pretty robust immune response. And the hapten that we use is called TNBS. Most of our experiments we do on day 0 and then day 5. And it looks a lot like Crohn's disease, which makes sense because it's thought that in Crohn's disease, it's immune, but it's not autoimmune. So it's caused by antigens in the colon, in the lumen. So we can't ask the rat if he hurts. And even if we could, he's sedated. So how do we know if the rat is in pain? When you go to the doctor's office and you're in pain, and the doctor pushes on your abdomen, you'll crunch up your abdominal muscles. We call it guarding. If you have appendicitis, you might punch him and jump off the table. The rat does this too, even under anesthesia. So we insert a balloon into the colon, inflate it to 4 different pressures, 20, 40, 60, and 80 millimeters mercury, with the normal threshold occurring right around 40 millimeters mercury. And then we insert electrodes into their external oblique muscles, and we can measure how much the rat is guarding. So on the top, you see this is a trace of electromyography, and the way that we report it is we integrate and report it as an area under the curve for during stimulation, and we subtract from that the baseline. And so this is the normal response before the hapten has been given, and after we induce inflammation, you can see that the response is markedly increased, meaning that we have induced visceral hypersensitivity. Okay, So we've talked about visceral pain, visceral hypersensitivity in inflammatory bowel disease. Now we need to try to do something about it. And one way to do that is to look for mechanisms that are involved with the pain. And so we looked at a molecule, a protein, called TRPV4. It's a relative of the same protein that causes the hot sensation when you eat chili peppers, TRPV1, the capsaicin receptor. When something binds or activates it, it opens up and allows ions to rush through, including calcium. It's widely distributed, and importantly, it's in those pain fibers that innervate the colon. And it has a number of ligands. We use this one. These are things that bind to it and activate it, as well as endogenous ligands that are involved with inflammation. It was first thought to mainly be involved with cell swelling, but people later showed that it's involved with pain. And interestingly, they showed that it was involved with pathological pain. When they reduced it, it had no effect on nociception, but they did not get increased hypersensitivity in response to inflammation. Importantly, it can be sensitized by the things that we talked about earlier, phosphorylation, and by proteins that have been shown to be involved with pain and inflammation. Different kinases, those are things that phosphorylate proteins. More recently, it was shown to be involved in visceral pain. The neurons that innervate the colon have more of it than other neurons. It's upregulated, or there's more of it in patients who have inflammatory bowel disease than those who don't. And knockout mice, so if you reduce it, they seem to have less pain, including in models of inflammation. So we decided, considering all of this background on this molecule, TRPV4, that it would be a good one to look at as a mechanism in our model of inflammatory bowel disease. So the first thing we wanted to do is just look and see, is there any change in the amount of it in these neurons when we induce inflammation? And so on the left, you have protein from animals that have no inflammation, and on the right, protein from animals that have been given TNBS. And it does appear that it goes up. But that doesn't tell us a whole lot regarding its involvement. It could just be, maybe it just goes up and it's not doing anything. So the next step was to reduce it in those neurons. So in the neurons that innervate the colon, we dropped the amount of TRPV4. On the left, these are control animals. On the right are the knockdown animals. And it does appear that knocking down this protein attenuates visceral hypersensitivity, indicating that it probably is involved. And this is just to show that we did, in fact, have a reduction. So the problem is, this protein, there are no good drugs out there that antagonize it, that act on it and block its actions. When we started this project, there were none. That's why we did the knockdown instead of just using a drug. So there have to be other mechanisms. We know that other drugs work by decreasing the amount of phosphorylation in cells. Clonidine is a good example. It's a blood pressure medication that decreases sympathetic outflow from the brain And it does this by reducing phosphorylation in the cells. And so we have this protein that we know is activated by phosphorylation, and we know that we have drugs that can decrease that. And so we wanted to see if there was some kind of an interaction between the two. So clonidine seemed like a good candidate. So it acts by binding to alpha-2 adrenoceptors. These are receptors that are involved with the sympathetic nervous system, but instead of increasing the fight or flight response, they kind of act as a feedback mechanism and reduce it. Okay. And aside from being involved in blood pressure regulation, they have been shown to have analgesic effects. They can reduce pain. Oftentimes they're used as alongside anesthesia and can reduce the amount of, say, opiates that a person needs. Most of the known effects are central. As I said, reducing the amount of sympathetic outflow. But they have been shown to have some peripheral actions as well, which is important for our study since we're studying peripheral sensitization. They've been shown to have increased expression in those the neurons, the peripheral neurons following a nerve injury. And clonidine administered peripherally can have an effect even if it doesn't go systemic. So kind of to wrap it all up, the basic idea of this project was this TRPV4 was shown to be important for inflammation and visceral pain. And we use a rat model of IBD. It's sensitized by phosphorylation, and alpha-2 adrenoceptors reduce phosphorylation and have analgesic effects. So we wanted to see if there was an interaction. And so the hypothesis was kind of stated in the title. Visceral hypersensitivity associated with colon inflammation is reduced in part by alpha-2 adrenoceptor activation and its modulation of TRPV4 channels on visceral afferents. So if we want to find an interaction between alpha-2 adrenoceptors and TRPV4, first we have to show that they actually are analgesic in our model. And it turns out that they do appear to be. So again, these are those EMG recordings in response to colorectal distension that we talked about earlier. Before TNBS, after TNBS, the responses go up. Clonidine's vehicle had no effect. When we give clonidine, visceral hypersensitivity is attenuated. And then we wanted to see, is this effect through alpha-2 adrenoceptors? And to do that, we gave a drug that works opposite of clonidine. So rawolsine is an antagonist at the alpha-2 adrenoceptor. And it does return some of the visceral hypersensitivity. Not completely, but that's probably dose dependent. And so here is just a graph showing data from 3 different rats kind of put together. So again, TNBS sensitizes, clonidine reduces that, and rawolsine returns some of the hypersensitivity. So we also looked at clonidine in naive animals for 2 reasons. One, clonidine is sedating. And so maybe this reduction that we see here is just because clonidine put the animal to sleep and he's just not responding anymore. And so if we do that in naive animals at the same dose and do not see a decrease, it indicates that its effect is probably not through sedation. Another thing that it tells us is its effects are on pathological pain, and not normal nociception. Because if it was just making the rat not feel any pain at all, again, you should have seen a reduction. And so here, we just wanted to make sure that after giving rauwolsine, when you saw it bump back up, that effect was not simply because clonidine was wearing off. And so we gave its vehicle, rauwolsine's vehicle, and it had no effect. Okay, so if there's an interaction between these two proteins, they have to be in the same neuron. And so this is just staining of the dorsal root ganglia to determine whether or not both proteins are present in at least some of the same neurons. And it appears that they are. The green is alpha 2 and the red is TRPV4, and at least some neurons have both. So next we were trying to determine how the interaction is occurring, and we hypothesized that it was through phosphorylation. So first we wanted to see, do TNBS animals have a higher amount of phosphorylation of this protein? And second, does clonidine reduce it? And so we stained for phosphate groups and compared it to just total protein, and it does appear that TRPV4 is more phosphorylated in our IBD model, and clonidine reduces this phosphorylation. But again, that doesn't tell us directly if it's involved. You know, it could just be, in inflammation, almost everything is probably more phosphorylated. So that doesn't necessarily tell us that it's important for pain. So to do that, we have to look directly at the peripheral nociceptors. Because the effect could also be central. The behavioral studies do not tell us anything about what's going on where things are happening. It could be anywhere from the cortex down. So we recorded directly from peripheral afferents. We severed them from the spinal cord to ensure that there are no top-down influences. And each of these little lines represents, when you blow them up, they look like that, an action potential of one of those peripheral neurons. And so this particular neuron, it's not doing anything. And then we inflate the balloon in the colon, and it begins firing. When we give TNB, 4-alpha-PDD, sorry, the agonist for TRPV4, and inflate the balloon, it fires more rapidly, meaning that this drug sensitized the neuron. And then clonidine seems to reverse that sensitivity. And this is just a few cells put together to kind of give you an idea of what's going on. Each neuron's a little bit different. So this is the last part of my project and the only thing that I have left to finish before I can defend. So as you can see, I mean, there appears to be a trend there, but it's not significant at this point. It's only 3 neurons. And we used a different agonist, did the same study, and the effects seem to be similar. So, in summary, it appears that TRPV4 is increased in our model of inflammatory bowel disease. It appears to have increased phosphorylation. It appears to be necessary for visceral pain in this model because when we reduced it, we also reduced the pain. And clonidine is not only an analgesic in our model, but it appears to at least have some interaction with TRPV4. All right, any questions? Yes, sir.
To the microphone.
You referred a couple places there to knockout rats.
Yes, sir.
And it wasn't obvious to me what that is or how they fit into the experimental scheme there.
Okay. The studies done with knockout animals showed that TRPV4 is necessary in whatever model they were using. What a knockout is, it's usually mice because they're easier to work with. And so they totally knock that protein out. And so that particular mouse will not have any of that protein anywhere.
By doing
It's a process that I don't quite understand. Lisa may know, and we have a knockout person back there. But it's something that you do during development. So they I guess in the gametes, they cut the protein out. The DNA is put back together, and then they grow up without the protein. So it's a good model. The problem is, you know, a lot happens in development, and so it's one tool. So it's good to use knockouts, knockdowns. And now they have it where you can actually knock the protein out in specific locations. And so that's also helpful. And then you have, of course, agonist-antagonist studies to look at these proteins.
So clonopine is already used for blood pressure control in humans, right?
Yes, ma'am.
At what point could we look for this to be used for actual pain control in humans?
They do some. Clonidine is used some as an analgesic. The problem with it is it's very sedating. And so people don't like going home on clonidine because they're just sleepy all the time. But it can be used.
Okay, now you mentioned another substance that seems to reduce the effect of the clonidine.
Yes, sir.
Now, is that something that's used clinically? Is this a medication that's actually administered?
It's not. It's mostly used in the lab.
Okay.
There aren't very many clinical uses for alpha-2 antagonists. I could be wrong. There may be some.
Yeah.
But to the best of my knowledge, ribosine is not used clinically.
Because I was wondering whether maybe that would be, say, something they'd have to be concerned about if they were getting that for some other reason, then the clonidine would be less effective.
Yes, sir.
So.
I'm a little confused about how the body interprets the feelings of either pleasure or pain. I'm assuming it uses the same nerves.
Right.
In other words, I mean, if you're touching somebody, you know, the feeling of touch, gentle touch, feels good, whereas hitting yourself with a hammer is painful. How does the mind interpret the difference between the two? Do they know?
That is a really complex question. I guess at the most basic level, it starts with the type of neuron that's transmitting the sensation. So when you mention light touch, that's transmitted by large A beta fibers that synapse in slightly different places on different neurons in the spinal cord than, say, C fibers that are going to be transmitting pain.
So the body actually does have different nerve endings or nerves that are transmitting one or the other?
Yes, sir, they do. And that's one thing that can help contribute to pathological pain is sometimes those A beta fibers kind of switch to where they become painful. And that's one of the mechanisms behind allodynia.
You mentioned, I mean, there's certain people that you can blow on their face and it feels painful.
Yes, sir.
Right. I mean, it seems like something's gotten confused there with
It does.
their body.
Yeah.
And if you could figure that out, you might be able to make pain actually pleasurable. You know, people might look for it.
I'm going to let that one go, George.
So, as a follow-up to your comment about sometimes the A beta fibers start to transmit pain, and earlier you said that some IBD patients have pain even in remission. What is that? What happens there, or what are your thoughts, and what do you know about that?
One thing is I kind of misspoke. The A beta doesn't transmit pain per se, but it becomes interpreted as pain. There aren't many A beta fibers that innervate the colon or the viscera, for one. The question of silent nociceptors, though, is very important because we do see that, where you will have neurons that before didn't transmit anything or transmitted something else, and now all of a sudden they're transmitting painful stimuli, noxious stimuli. So,
from chronic activation of?
Chronic inflammation contributes to that. Also, say an insult at a very young age. And in that case, you see something more akin to irritable bowel syndrome. So you have an insult very early that sensitizes the neurons, and then you have pain in the absence of any pathology at all.
And then I have a second question. It's kind of a semantics question that I got from one of my committee members, and I couldn't really answer, but maybe you can since you're studying pain. Is there a difference between anti-nociception and analgesia, or can they be used as synonyms?
It's a good question. I do think I would say there is a difference. So anti-nociception would be blocking pain at the level of the, say, pain fiber. Analgesia is anything that reduces pain. So if you were to block pain, say in the cortex, block the perception of pain, you could still have all of these neurons all the way up to the cortex going mad and not feel pain. And you would still probably call that an analgesic, I assume.
With regards to the irritable bowel movement, if a patient has, for example, might have lost control of movement.
Yes, sir.
I know we're dealing about pain here. What would be the cure, I might say, to alleviate such maybe a loss of control or irritable bowel movement?
That's a good question. The colon is actually really complex because it has its own nervous system totally independent of the CNS. And so the problem with irritable bowel syndrome is a lot of what goes on with it is caused by a malfunction in the colon's nervous system, the enteric nervous system. There's a lot, 90-something% of the serotonin produced in your body is produced there, or a large amount anyway. So it's hard to say. It's hard to say if reducing these central influences would have an effect. They might, but we don't know.
Anyone else?
Did you bring the test questions?
I did, yes. I hope you were paying attention.
Okay, well, I'll take it up.
All right.
Thanks, Mark.
Thank you.